Greetings. My name is Lisa Reber, and members of the research team and I will be presenting ourselves during the presentation in time. So I'm just going to jump right in and get going at this point. And today we're going to talk about some research, a study we conducted. It addresses the COVID-19 pandemic and how it impacted adults with physical disabilities. So this is a qualitative study and it draws from a larger project. And this larger project looks at the factors that allow adults with physical disabilities who are living in low income and racially marginalized communities to live full and meaningful lives. Today's study focuses on part of the larger study. It looks at the impact of the pandemic in its early days. So about 1 year ago in April and May 2020. This COVID study, as I'll refer to it, explores the day-to-day experiences and perceptions. So from the start of the study, I and Dr. Mead, who is the lead researcher, wanted to be sure that we were well informed and that we accurately understood the information we learned from participants. We're both white women without physical disabilities. We do not reflect the target population. As a result, it was extremely important that we have others on our research team who do. Thus, as part of the larger study, we hired 2 community liaisons, Gina Dijon and Jamie Jr. Gina?
Good afternoon. I am Gina Dijon. I am currently the program director at the Disability Network and a lifetime resident of the Flint community. When I began this project as a community liaison for Flint, my position here was an information and referral specialist. My job was to answer phone calls and provide information about available resources and programs in the Flint community. I have worked with people with disabilities in various capacities for over 20 years. I'm very familiar with the challenges that they face on a daily basis. Here in Flint, we have a saying, when everyone else gets a cold, Flint gets the flu. So just imagine what that means for people with disabilities who struggle on a daily basis just to find the resources to survive and thrive.
And Jamie.
Good afternoon, everyone. My name is Jamie Jr. I am a woman with a developmental disability. I have cerebral palsy. I use a wheelchair or mobility device to get around. I am the mother of 1 child. At the beginning of this study, I was working with an organization called Warriors on Wheels of Metropolitan Detroit. It is an advocacy organization for people with disabilities, by people with disabilities. And currently I serve as the community coordinator for the City of Detroit's newly started Office of Disability Affairs. I wanted to work with this study because as a lifelong Detroiter and a member of the target population of the study, I had a lot of insight into different things and wanted to learn more. And as COVID developed, there were a lot of different aspects that seemed interesting. And
I met with Gina and Jamie weekly. They expanded my awareness of issues related to disability and to race and to the specific communities we were targeting. More recently, we added Jody Kushmer, our research associate, to the team. Jody?
Hi, I'm Jody Kushmer. I've been a research assistant for the University of Michigan Department of Physical Medicine Rehabilitation for about five and a half years now. I'm also a woman with cerebral palsy. While working on this project, the thing I found most interesting is the resilience and the creativity of people with disabilities as to how they live their life during the pandemic. And now I want to go back to Lisa so she can tell us more about their background.
Thank you, Jody. And I'm Lisa. I have a PhD in Justice Studies, AKA Social Justice, and I'm a qualitative researcher. And I've been working with the RRTC for about 1.5 years now, and on this larger project. So the initial analysis of the interview material for the COVID study was conducted by myself and Dr. Mead. Following this, Gina and Jody provided feedback and critique. Together, the 4 of us re-examined the data and developed stronger ways of thinking about it. So our goal today is to share with you some of the things we learned from the people who were in the study. But first, I'll tell you a little bit about the study, who was in it, and where we conducted it. So in the early days of the pandemic, Wayne County, which is in the southeast of Michigan, soon followed New York City as an epicenter for the pandemic in the US. Several weeks ago, at the end of March, Michigan was reported as having the fastest growing COVID-19 case rate in the country. Key reasons for why Southeast Michigan was an epicenter are the same reasons we chose these 2 cities in this region as the sites for our study. Both Detroit and Flint have high percentages of African Americans, low-income households, and people living in poverty. To participate in the COVID study, individuals had to have a moderate to severe physical disability for at least 5 years, and they had to live in Flint or Metro Detroit. We attempted to include only or mainly those of low-income households, which we identified through the zip codes. The study also included key informants, and these were people who had important insights about the experiences of the target audience. For our larger study, our goal was to have a racial demographics of our participants reflect that of each city. However, the individuals we interviewed for the COVID study were recruited prior to the pandemic. As a result, we simply interviewed those who we already had. And the number of participants in the COVID study, as a result, did not evenly divide between the 2 cities. Most of them ended up being in Detroit. But interestingly enough, for Detroit, the numbers were spot on. Detroit is 79% African American, and for the COVID study, 80% of the participants were African American. So this table shows the 16 participants I interviewed one-on-one about the pandemic. The green and blue colors reflect the racial ethnic groups, blue for African American and other people of color. The lighter color are the participants, there were 12, and the more intense blue and green at the bottom of the table are the key informants. The key informants themselves were not necessarily from low-income communities. However, they were able to speak to the experience of those who did live in such communities because of their work with them. 3 of the 4 informants also had physical disabilities, and inevitably, their interviews also included their own experiences. Only 1 didn't have a disability that would have qualified her for the study. The interviews lasted about 1.5 hours. On the right, you'll see duration. Duration refers to the amount of their interview that addressed issues relevant to the pandemic. It averaged about 15% of the entire interview. For 3 of the participants, it was 25% more of or more of the entire interview. During the interviews, we talked about many different topics, including social supports, the built environment, healthcare access. I asked specifically about the pandemic, but usually it came up many times throughout the entire interview.
When we were analyzing
From the interviews,
when we were analyzing the data, 5 themes appeared to become prevalent in regards to what people with disabilities were currently dealing with the COVID-19 pandemic. The first theme was invisibility. Many people with disabilities thought that they were represented in how the COVID-19 pandemic may impact them. The second theme was isolation. This was a major theme with the general population, but it is also more impactful for people with disabilities because they will rely on their social support more than others. Another theme we saw was unable to access health care. And for people with disabilities, this is very important because they need more in-person health care to help with their spasticity and to get both text and injections and such. People with disabilities also use personal care assistants to help them with daily living activities. And it was also hard for people with disabilities to find resources in their community to use, such as how to find grocery delivery services because they couldn't go to the grocery store, or transportation that didn't surround them by a bunch of people. So once we found these things, we found there were some overarching factors. Basically, there's a continuum, which we'll discuss in more detail, with the risk on one side and immediate needs to be met on the other. And a lot of people with disabilities needed to balance whether they wanted to take the risk to get their needs met or not take risks and not have their needs met. So to balance that out, people with disabilities use accommodations like food delivery services, having PCAs live with them, and such. So we'll be talking more about that later in the presentation.
the individuals in the study were typically in a difficult position with difficult choices to make. As Erica said,
if you have to stay in the house because you're susceptible to what's going on out in the public, then what do?
So how do they get their needs met?
When participants were forced to choose between not having needs met and having them met, they typically chose the latter.
As Shanta said,
they go out maybe once a week and do the grocery shopping. And so it stresses them out that they have to get on public transportation.
And Carnice added,
because, you know, you got the president talking about he wants to reopen like yesterday. So that causes some anxiety, and especially for people like me that are more at risk.
Not all participants said they felt at risk. Some didn't think their circumstances were much different from those without disabilities, but many did.
Mainly the minimization of risk had to do with whether or not they wanted to have healthcare providers and personal assistants assist them throughout the pandemic. Many people use their personal care assistants and healthcare providers as support throughout their lives, so not having the support was not good for them, both physically and mentally. Many people with disabilities had no choice but to have their healthcare providers or personal assistants come into their home to break their quarantine bubble because they needed this help. Once the people with disabilities have their personal care providers in their home, they did not want to rock the boat if their personal care assistant did not wear the correct PPE or abide by COVID-19 guidelines because the person with disabilities needed the care and they couldn't get it from anywhere else. So if they upset or anger their personal care assistant, they might not be able to find somebody else to help them. The person with the disability, to avoid losing their personal care assistant, also tried to normalize the situation, saying it's okay if they don't wear masks or things like that because they're only with me for a couple of seconds, or I need this help, and you know what, it's okay if you're not doing this because as long as you wash your hands, we should be okay.
Or, as one key informant put it,
they're just saying, I value what this person can give me more than I value the consequence. The pandemic
most frequently talked about was isolation, fear of it, and the need for connection. It was discussed by 9 of the participants. I think for people without disabilities, it can be difficult to understand why the pandemic is any worse for those with disabilities. Feelings of isolation and access to healthcare and resources were fairly common. They were experienced by many in society, but it is different. As Laura, a key informant, also said,
the pandemic is further isolating people. So if people felt isolated before, then it's like taking a deeper dive into isolation.
Sources of connection and community can be different for people with long-term disabilities and chronic diseases. One important comment revealed the important role of those in healthcare, important because of the human connection that they can provide. Medical practitioners, rehab services, physical therapy, the people who do these jobs play an important role in providing social interaction. When these forms of connection and interactions were put on hold, the small circle that participants engaged with shrank, and in many cases became non-existent. As Ramon said,
I used to go to therapy like 4 times a week, but of course I can't do that. I don't really talk to anybody.
When isolation is already an enduring, unending part of one's life, the isolation that the pandemic brought can result in that isolation being more intensely experienced than it already is. During the pandemic, participants had to continually weigh 2 options: not having their needs met or engaging in risk to have them met. In many cases, the need to choose between these 2 options could have been avoided had accommodations been provided. This was the second overarching factor that we mentioned. By accommodations, we're talking about like the presence of services, environments, policies, and how these can help make access to resources not a privilege, but a right. The participants' narratives, they reflected the inability to access accommodations, as well as the negative impact on their physical and mental health. During the pandemic, participants had received almost no accommodations, not for their healthcare needs, not for the resources they required, or for the assistance they required in their home.
And for people with natural supports, oftentimes it was even more traumatic. People like myself, for example, who receive all of their support from their family, don't have much connection to community organizations or receive the necessary information about how to acquire free or low-cost PPE and other things to help them feel safe. They also found it difficult in some cases to find connection or to get needed stimulation.
There's also other factors that can provide some individuals with greater access, and hence the ICF model raises awareness of the specific factors that can privilege and as a result give access and accommodations to some people and not others. Personal factors include such things as race and socioeconomic status. And environmental factors include the built environment, the people around us, as well as the attitudes that those people hold. Personal and environmental factors interact and influence the relationship between impairment and functioning. So the ICF's personal and environmental factors can be looked at in relationship to our participants' experiences. Their experiences reflect where identity and personal circumstances interacted with systems and structures and attitudes. And in the process, they reveal the potential importance of such factors as racial identity, networks and connections, and the power and privilege they grant. As an example, Steve and Grady are two young men in our study. Both men required 24-hour home care assistance and were in COVID at-risk groups. Steve, like Grady, had multiple caregivers entering his home during the pandemic. Steve saw this as high risk. However, unlike most folks, Steve was able to change his situation and live with only one caregiver. Both Steve and Grady have limited education beyond high school and live in low-income neighborhoods. But that's about where the similarities come to an end. Steve is white. Immediately following his injury, he received support from a local nonprofit organization whose director groomed him to be a disability rights advocate. Combined with the knowledge and skills acquired and his extensive social networks and the connections he developed, Steve could conceive of different possibilities and he could change his circumstances. Grady, in contrast, is an African-American man. He was not connected to any disabilities groups, and he was socially isolated and lacked social networks and resources and connections. Unlike Steve, Grady described an upbringing lacking warmth and support. All of this, of course, occurs within a society that puts a great degree of value on whiteness. Steve and Grady's experiences help make visible the potential impact of environmental factors on personal factors and vice versa. The model of healthcare disparities and disability builds on the ICF. And this is a framework for helping us think about the personal environmental factors and their impact on one's experience with healthcare. The model focuses our attention on the factors that can lead to disparities, including things like accommodations that may or may not be provided. This particular factor, provider attitude, received quite a bit of attention in the early stages of the pandemic, in the media, in commentaries, and in op-eds, in relationship to issues of rationed care. If healthcare resources were being limited, who gets priority? Or more importantly, who will be deprioritized? Interestingly though, when asked about this, none of our participants expressed explicit concern about receiving care if they needed to be hospitalized, though some did hint at it. As Tabell said,
I would hope that I would get the fair treatment, but I wouldn't. I don't know if I would or not, so with the underlying issues that I have already, I believe I will be prioritized because I have those underlying conditions.
Another aspect in relation to access to care and rationalization of care would be access to one's personal assistance. In the beginning of the pandemic, people were not allowed to have family members or friends in the hospital with them. And for people with disabilities, this is more of a burden because people that are your personal care assistants know more about you than your healthcare providers sometimes because they are with you day to day and help you with your physical needs. Now, if you don't have that person there, how do you know that your needs are going to get done? Nurses were busy during the pandemic. People were worried that they wouldn't be able to get all the health care that they needed in the hospital. As Steve states,
Steve, who is the man above, who had the ability to alter his living arrangement, felt far less confident about what would happen if he had to go to the hospital. As Steve said,
when a person, if they're paralyzed and they're recovering, there's not time to have people sitting in a room, waiting on you. A person like me, I need 24-hour care. It's about survival, really.
In the early stages of the pandemic, go ahead, Jamie.
In the early stages of the pandemic, there was talk of rationing care, going back to several World War II instances where doctors made the decision based on what they perceived the quality of life of a person to be as to whether or not they will receive care. Several advocates rallied, and it resulted in Governor Whitmer signing Executive Order 2020-64, affirming anti-discrimination policies and regarding certain healthcare providers to develop equitable access to care protocols.
Participant testimonies provided us with examples of the challenges they encountered as a result of the pandemic, as a result of the lack of accommodations that can bridge need and risk. Looking closely at the personal and environmental factors helped reveal distinctions in their experiences and how this can be the result of their particular identities. Identities that impact access to accommodation, access to resources, to healthcare, to human connection, and to less isolation. This study helps make the invisible visible. It helps make more visible certain members of society, their care, their unique health concerns, and the resources they require. It also makes visible the need for greater inclusion of people with disabilities in disaster planning at all levels and in the emergency response policies that would accompany it. Gina, Jody, Jamie, and I, thank you for attending, and we're happy to answer any questions you might have. Thank you.
Lisa, there is a question in the comment field. Can I read it to you?
Yes, I need to stop sharing my screen just a moment.
Okay. This is from
Allison. Did you want to read first, Allison? Wait a minute, Gina. Okay. Allison, do you want to discuss the protocol here?
Yes, thank you. I'm going to confirm with you. There was one question that popped up very early during the webinar. And from Catherine Wilson, she actually why just no income. Since diversity is treated the same, whether low income or not. It would have been important to see if income made a difference for those with disability. Do you have any thoughts about that?
For one, sure, I can address that. The study in general, the broader study, was looking at more marginalized population. the majority of research being conducted is on more convenient populations, convenient meaning middle class and white. And so Dr. Mead, who designed the project, specifically wanted to target those populations that were more often being neglected. And so that meant the low income and the racially marginalized. And hence that's what we had available for our COVID study of 2, were those that we were targeting.
And then we had a next question. How do we move forward? And this came in just after you finished your presentation.
Okay, okay, how do we move forward? I would say, as I concluded there, in terms of involving people with disabilities more in the planning stages and preparing. Does anyone else, can anybody else add to that?
Sure, I agree with you, Lisa. Having individuals with disabilities at the table when planning things like interventions, resources, and the like will help us move the needle, because who knows better what we need than us? Would anybody else like to say anything?
You could contact your local CILs to see how you could support people with disabilities in your local area. Centers for Independent Living. They're in every community. Like the Disability Network here in Flint. You could contact your CILs to see what kind of things you could help with, volunteer for. So that would be a good way to start.
Yeah, I'm reading in the chat, and one person talked about being a caregiver and an advocate for someone with complex, invisible chronic illness and profound medical trauma related to PTSD. And she says, I am currently not allowed into the ER, despite the fact that their medical PTSD is why I am there. Stories like that, they hit me really, really hard. I work with a lot of individuals that have developmental disabilities or cognitive disabilities. As a matter of fact, my nephews, I have 2 nephews that are autistic, and they lack the ability to communicate effectively sometimes what they need or what they want because of their social anxieties. So it's always troubling to me that no one is allowed. I also had a personal experience. My mother, who was 82 years old, she contracted COVID while she was in a rehab care facility. And not only could we not visit her at the rehab care facility because of the protocols, but when she was at the hospital, we couldn't visit her. And the hospital staff barely took our calls. So I can definitely relate to how anxiety producing it is. It looks like we have a hand up.
Yes, I was going to remind everybody that if anybody needs to speak to ask their question, please click on the raise hand icon at the bottom of your Zoom window. I'm sorry, I did not remember to do the reminder instruction, but someone did raise their hand. So I'm gonna allow this person to talk, and they should receive a prompt to unmute themselves.
What's the person's name, Allison? Maybe that would help them.
Yeah, I think she could speak now. Can you speak? It's Carolyn Growy.
Hi, this is Carolyn Growy. I'm associated with both the University of Michigan and down here in the South with the University of West Florida. And I'm just curious with the research that was done, if there's any thought or inclination to look at more in-depth regionally or a broader study to look at the pieces, because as both of your guest speakers also shared, there are CILs, and the CILs are across our country, or actually across the world, but very prevalent across the United States. And there are centers in many low-income areas throughout the country, as well as the pieces to look at how are people treated day to day when we have individuals with disabilities that are being seen in medical care and other places as compared to our counterparts, and also looking at what the next outcomes will be, since we know that there's lots of long-term pieces that are impacted with disability and COVID, as well as yet, what will be the vaccination protocols going forward past this first round. So I'm just curious what the next steps to the research may look like as a broader community.
Specifically related to COVID, there's no clear next steps. We have the broader, larger project that we are still continuing with on adults with physical disabilities from the marginalized communities. But inevitably, as we've interviewed most of the people we have, but when we interview more people, we will continue to ask about the pandemic. But unfortunately, the majority of our participants were all interviewed prior to that. So we can't go back at this point and get more information on that. It will need to go into a new project.
Lisa,
I might also say, somebody asked here about, are you addressing another question that's up here in writing?
Yeah,
there's a question up here on the collection of data. Right, and so collecting data to be ensured, so we know who's getting the vaccine and who's not among individuals with disabilities. And it may be that you might know something about that, Jamie, from your position.
Yeah, actually, there is the Protect Michigan work group commission that exists in Michigan under the Michigan Health and Human Services division of the government. And there is a disability work group that I sit on, and we've been working on trying to convince healthcare providers that collecting the data is necessary so that, as you said, Jerry, we can develop equity plans. But you would be happy to know that the disability work group has put together a manual for best practices. So things like providing interpreters without reservation, things like providing for individuals with mobility disabilities, people with service dogs, actual protocol on how to welcome and make people with disabilities feel comfortable in mass vaccination sites. You can find more information on that at michigan.gov/Protect Michigan Commission, or PMC. I hope that was helpful.
I want to bring up that someone else also raised their hand. His name is Thomas Houtman, and I just asked him to unmute himself. There we go. Try again, Tom. I'm sorry.
How about now?
Yes.
Hi, everybody. I sent my question in the chat, but then I rose my hand because I wasn't sure which you preferred. But I don't remember seeing numbers or it coming up in a slide on whether anyone talked about being admitted to the hospital during the pandemic because you know, they made a choice and a compromise, and as a result, symptoms worsened and they had to be readmitted. because I work with the spinal cord injury population, and that I found that amongst some of my peers. That's it.
Okay, I only interviewed one person who had been hospitalized, and he was hospitalized before it even became an issue, or I mean, before it erupted. And he was an intensive care unit and everything, but he went in February, I think, and he was in for maybe 4 or 6 weeks. And he was in by himself, but he was able to, yeah, no, he would have been fine in the hospital on his own. He did not require 24-hour caregiving, so it wasn't an issue for him while he was there. But otherwise, no one else had been in the hospital. Is that answering your question?
It does. Can you hear me?
Yes, I can.
It does answer it. I just I know of an individual that really called it it was a close call because they were afraid to go to the hospital due to obviously contracting COVID. So it was just a really difficult choice, and wondered if you found that. So thanks for sharing that.
No, like I said, it wasn't. And one, he didn't know about the thing of COVID at that point. And two, I think he collapsed, actually. The ambulance came and had to take him away. So it hit him quite hard.
Okay. Thank you.
Okay, I'm going to mute time right now. And there's a next question by Alice. Her question is, what about looking at the environmental factors more in depth, e.g. lack of policy, lack of support, access to vaccine, etc. by identifying the environmental barriers one should or could develop strategy to eliminate or minimize the environmental barriers?
No.
I'll just take that on.
Definitely very good. No, that would be great to look into. I also see that Els asked for our definition of disability. Jody, how would you like to answer that one? Oops, we can't hear you. Volume.
Yeah, I'm asking you to unmute. Yeah.
Got it, sorry. We're mainly focused on people with physical disabilities. They can have a variety of disabilities from arthritis, cerebral palsy, spinal cord injury, different things like that. So we have a wide range of people. It has to affect their mobility in some point. And we also have some people who also have mental disabilities as well.
Okay, great. I'm going to, I see Michelle Mead also raise her hand. So I'm going to allow her to talk and ask her to unmute herself. Michelle Mead.
Okay, thank you. First of all, thank you for putting together this presentation and bringing us this information. Hopefully I am not showing you all of my house, but you can see me instead. No, you can't? Okay, sorry. Let me see if I can turn around. Okay, then you'll just hear. That I guess there are so many great points that people have brought up. The importance of using this information to change policy, to be proactive. The importance of recognizing that this is only a slice of the picture of what's going on, and recognizing that there is other research out there. And I think this supplements and complements it. Once again, recognizing that this is part of the larger ROTC project. And so this provided some this study really sets the stage and provides some of the qualitative understanding. It's also being complemented by a quantitative study in this area and surveys being conducted. And then it's being followed up by community surveys in which we are going to be reaching out to CILs and other organizations across the country to have them identify what best practices are. Here at the University of Michigan, I think we have heard the concern from individuals with disabilities, particularly about hospitalization. I guess my sense is that everyone needs an advocate when in the hospital, and so it is problematic not having visitors, not having people who can be there to help vocalize that, and have worked with the health system to develop guidelines, both for visitation or for care partners, as well as just best practices with treatments, with vaccination sites. Once again, having individuals with disabilities at the table and proactively making sure that any guidelines that are developed recognize the unique challenges that are posed. So there's a lot that I know we're talking about and discussing, but I think it all fits in within a broader context. We all use the pieces from, this study and others to continue to advance the policy and to recognize the impact of systemic racism and ableism and hope to move the dial to improve outcomes and lives.
I do
Michelle, if I could ask. Sorry, just a minute, Jamie. Somebody asked what would be government agencies with whom this information would be useful to share. Might you have any direction there? And Michelle's gone. Is she? Okay. I'm not sure about the answer to that. Jamie, you actually might have some ideas in terms of agencies with whom would be interested in this information, governmental agencies.
I'm sure MDHHS would be interested in this information. As I said, the Protect Michigan work group, the Protect Michigan Commission and its work groups, as well as even the Detroit Health Department would probably be interested in this information to help further work on enhancing their programs. One thing that I neglected to mention during the presentation that I want to make sure that I said right now is that Executive Order 2020-64 did provide for sign language interpreters to be present for individuals who were deaf or hard of hearing. But it did not alleviate the anxiety of not being able to have a loved one visit you or be in the room with you. So I just wanted to put that out there, and I apologize. I neglected to mention that during the presentation. I saw that Jerry in the chat invited us to join him for the FEMA Region 5 work group or presentation on May 11th. Thank you, Jerry. I just wanted to say that I saw that, and I'll make sure that that information gets to the other presenters.
Thank you. I want to know that Tim and Gary says, please reach out if we can be helpful from the show. We have conducted check-in surveys and have also held a vaccination clinic in our CIR. And she also commented 3 minutes later, ACL in Washington, DC, visibility rate legislature, which I'm assuming she is referring to the government agency.
Mm-hmm. Mm-hmm.
Are there any other questions? We have been receiving some really excellent questions. Thank you so much. I don't see anybody waiting.
Allison, if I could point out me. I just want to let people know that there will be an evaluation afterwards, and there's a part specifically for if you have a physical disability, and questions about your experience and how it compares to the findings from our study. We're really curious to know. It was a very small population, right, that we included the sample, and how does your personal experience, does it align with it, or is it completely different? So.
Thank you so much. I think unless anyone else in the panel could have anything to add, I think we are done with our presentation. Just anyone else from the panel could have anything to add here? No? All right, I want to say thank you to everybody who presented and attended. I hope you learned a lot from each other, and I hope you all have a great day. Take care.
Thank you. Bye.
Thank you.